cutoff point, and it should not be. I understand that these are the outcomes which are highlighted in the study, and somewhere other outcomes may not be, may not be that available in those limited studies. So if we want to take them, we should take the clinically relevant time points, and if the authors have reported within that clinically meaningful time points, say reversal, etc., we should report. Otherwise, we can put them into, we can exclude them.
Sure.
Yeah, I have a small comment to make. I think the fourth point in the important outcomes. Uh, can we go back to the screen?
Yeah, sure. Surpreet, you want to share the other version, the latest version you had, or you want me to share the previous version? Surpreet?
Sir,
One more,
actually,
sorry.
yeah. Can I speak?
Yes,
Hello?
Surpreet. Yeah.
Yeah. Actually, we had this great opportunity last time to be under, very good supervision. So I had made a list which I had shared earlier, and I just reiterated that list as alone outcomes, the way you have made. So I just wanted the group to have a look at that as well, which might help all of us to simplify. As Sir has suggested, it might have same points as Sir has suggested, and it might need some improvements. Definitely, it might. So, if possible, we can actually go through that also once, if
But do you
there is
want,
time
yeah,
permits.
to answer Dr. Ravi Shankar's comment, is there in that as well, in the same section? Or so do you want to pull up your document, or should I just open up the previous one so that?
Sir, it is up to, the rest of the members. It is just a suggestion.
Sure. Why don't we answer Dr. Ravi Shankar and on the fourth point, and then
Yeah.
we'll come back to your guide. Yeah.
See, the fourth point here mentions needs for additional pharmacotherapy. So the shock is managed by this vasoactive inodilators. So this is not very clear. I mean, we should be having what is that which we are talking about. Means whether we are talking about use of multiple inotropes as an outcome or not, because shock is obviously managed by fluid and these kind of agents. So this is to be clarified.
The specific
And
definition. Yeah.
yeah. And second thing is that we should also incorporate the adverse effects of the use of the medications. We can have things like severe tachycardia. We can have hyponatremia. So these, I think, one more intermediate outcome can be this. As I fully agree with this Rajan, that this important outcomes are very, like mortality and neurodevelopmental outcome, and we can have BPD also as a part of it. But these are the important ones. But everything else can be intermediate. Yeah.
Sure. Just to answer you, I think what that's why initially what I said was like these are the outline, the important outcomes. The specific outcomes will change as per the question. So we are comparing certain inotropes 2 versus 1 or 1 versus another one. Then the outcome is different, like and and that's why here we just wrote this as a outline. And the outcome will be specifically changed for that particular sort of question which you are trying to address. But yeah, we got your point, sir. We will try to be more specific, and we'll look into the adverse outcome as well for the pharmacotherapy. So Surpreet, you want to share that new, just without wasting time, because already 4 o'clock we have to go through a lot of questions. So just quickly show that document which you were saying, Dr. Surpreet. I think her video is gone. Are you there? Hello?
She has started.
She started. Perfect. Okay. Yeah, correct. This is that, sorry, second version. Yeah, please. Yeah. So here we have that, serious ADR and cost of care as well. Yeah, correct. So the first, I think critical outcomes remain same, just little bit better organized, and end organ dysfunction, AKI and cardiac injury, I think she added just now, so that is also there. Perfect. And the important outcome duration of NICU stay, hospitalization, re-hospitalization post-discharge, serious adverse drug, and cost of care. And of limited importance, the blood pressure echo parameters, improvement in the metabolic parameters, time to recovery from hemodynamic stability, and we'll define that specifically, and number and maximum strength of inotrope required. So multiples and what doses they required. Yeah. So this is little bit going into that further specific, but as I said again, question wise it will change.
So overall list of outcomes, whether they are critical or important, will remain same for the guideline as a whole.
Right. Yeah, correct. But again, I mean, if specifically for the inotrope, we thought there might be little bit the critical will remain same, but the important probably might change, right, as per the question. Or we keep it same for all the questions.
Kiran sir, it should be IVH more than grade 2, not more than or equal to grade 2, more than grade 2.
Okay, we can correct that. Yeah, 1 and 2 is not included, more than 2, 3 and 4 is included. Yeah. Okay, fine. So we'll go to the questions. Yeah.
Yes, we can go to questions, please.
Yeah. Okay. Sure. Sarpreet, can you stop the screen and I'll open up the questions. Yeah. Dr. Sarpreet. Yeah. Thank you. Okay, so just starting with clinical questions again. So few questions which we wanted to definitely sort of address, and we've written in the PICO form. Outcomes are not mentioned as we initially mentioned. So first question is clinically objective parameters for diagnosis shock. So in that we will try to address clinical parameters along with echocardiographic parameters. Now again, we will have a sort of a blanket specific questions only, but this is what we're trying to cover in this. And then second, whether echo based diagnosis of shock is earlier and more accurate than the clinical assessment. So in the diagnosis, two things we will try to address. It should be a clinical diagnosis only or clinical along with the echo for the definition of the shock and the diagnosis of the shock. And going on to then definitions related to the blood pressure. So question we'll like to address is invasive blood pressure better than non-invasive blood pressure in the neonates with shock. Then gestational age based working definition for blood pressures versus population based centile charts. So again want to address the definition of the blood pressure. And then third is therapeutic target endpoint for blood pressure value in neonates, 5th or 50th percentile. So how you define the reversal of shock or like the starting and the end point of the shock based on the blood pressure parameter. And then permissive hypotension versus gestational based treatment of hypotension, especially in the extremely low birth weight, extreme premature babies where there could be numerical hypotension. So that question we would like to address. And then after blood pressure, the question on capillary refill, is the capillary refill time is reliable marker for diagnosis of shock. And then some other questions we thought we'll just keep it option. So one is about definition, but whether we can have a question just relating specific definition for different types of shock, and how to differentiate those clinically those types of shock based on clinical criteria, and relevance of clinical parameters such as tachycardia, decreased urine output, pulse volume assessment for the management of shock. So whether we should include questions on that as well. But the previous ones we thought were important clinical sort of questions we need to address. So open to questions on this. Comment. Hello. So any comments?
So this is the comprehensive list. This is
No. So as I said, we
have
are
again questions.
no. This is not all questions. So we have divided questions into clinical, biochemical will come. Then there is a non-invasive, invasive. So monitoring like echo and non-invasive parameter will come, and then questions on pharmacotherapy, vasotherapy. So we have 4 documents. I'm just opening the clinical questions first. We'll discuss this. Then we'll go to the next section. Unfortunately, with lack of time, I couldn't put this in the PowerPoint, so I'm just going by section wise. So these are the clinical questions we thought are relevant to address. So any comments related to these questions or in the clinical, anything else we think we should address?
I will make one comment and then Dr. Sajan, Dr.
Sure.
Shashikant, Dr. Ravi Shankar, you can come in, and then Dr. Bean sir can do the final comment. If you look at your list of questions, I think the question which is most clearly framed and which should act as a guide is monitoring invasive BP versus non-invasive BP monitoring in babies with shock. So this is a simple question which can be answered, which can be a question for a systematic review. That you start with this particular question, define your population, and then search for studies and look at what all studies have given the answer to this and what outcomes have been reported. Now, other questions need to be framed in similar manner. That our questions are specific in such a way that they are candidates to conduct systematic review. Yeah, that you can take that question, look out the study clearly, find out the studies or already conduct a systematic review, and then give your recommendation. So questions are overall fine. Just I think you need to make them more specific.
Yeah.
More specific.
Sure. Yeah.
And it will be good to have most questions as therapeutic statements rather than as diagnostic statements or as prognostic statements. It is fine to have diagnostic questions, but I think it is always better to have a therapeutic question because that will give better recommendation, better statement. They are easier to handle. Doing diagnostic test, systematic meta-analysis, and then coming out with a recommendation may be a bit difficult. For example, invasive BP monitoring versus non-invasive BP monitoring. Although BP monitoring is a diagnostic test, but it is framed as a therapeutic question. Similarly, if you look at question 1, that for diagnosis of shock, echo-based diagnosis versus echo plus clinical-based, clinical diagnosis versus clinical plus echo-based diagnosis. Now, what is gold standard or reference standard to say diagnosis of shock is there or not? So, in diagnostic test, those issues come. So, if you frame it in a better way, that in agree with shock, managing based on clinical criteria alone or managing based on clinical plus echo criteria, which is better? So now it becomes a therapeutic question that once you diagnose the baby with shock, I am managing based on clinical criteria, let's say BP, CFT, urine output, blood gas, versus also attaching echo criteria like IVC collapsibility or stroke volume or whatever they are. So try to make them more specific. That is how I judge, and maybe Sajan will be able to shed more light on that. How, let's say, if you want to conduct the study and then compare that diagnosis with diagnosis by echo.
Yeah, I agree, Dr. Deepak. So basically, one is in relation to the blood pressure, as you have told. One is in relation to the other signs of peripheral circulatory failure. What is that will be more kind of diagnostic test accuracy. The BP can be framed for the therapeutic or diagnostic test accuracy, but the peripheral signs, say core periphery temperature difference, CFT, those kind of thing can be included as a diagnostic test accuracy, whether they can identify or not.
sir, if I may add, I mean DTA is quite it's challenging, and we need lots of expertise to actually go through the process and grade it as well. So we should be careful framing questions which have to be addressed to a diagnostic test accuracy meta analysis.
Yeah. Any other comments?
Yeah, I think what Dr. Praveen sir's initial comments were that, we should be focusing more on the clinical parameters for the diagnosis and the management, because a vast number of the NSUs in India do not have access to the echocardiography. So if you bring that initially, then it becomes like, we are addressing only the needs of the tertiary care, hospitals. So trying to address the clinical criteria, the clinical, the management based on the clinical criteria and the biochemical aspects should be our first importance. We should give more importance to that. And obviously echocardiography has a big role to play, but that should be brought down. So I feel that we should focus more on the clinical things.
Sure, sir. Just on that note, I wanted to ask, should we have, for the definition for all types of shock, should we have a clinical definition? How you define a hypovolemic shock? How you define a septic shock? How you define
so one relevant. So one option, one question suggestion can be a mean BP based therapeutic endpoints. Basically, I'm talking of therapeutic endpoints. So mean BP based versus systolic and diastolic BP based. Usually the mean BP, why I'm saying this, mean BP is more in the is taken in the transitional circulation in the first few days, and later on the people tend to use the same kind of cutoffs. So you can think from that therapeutic end point of view.
Correct.
What should be the
So question 2 and 3 in the blood pressure, both you think are relevant, right? Yeah, this is, yeah. You're able to see the question 2 and 3, right? So that question we have addressed, gestational age versus the percentile. Yeah. So you and I think we will see what conclusion will be, whether we should go by percentile only, and then therapeutic endpoints. Yeah.
So I think what the message is that it's not that questions are not important,
right?
But the framing of them
yeah.
To be
correct.
And I can give you example of when the jaundice group was working last year. So for example, they had a question TCB versus TSB, right?
Correct.
Now you could frame it as a diagnostic test question, but you could reframe it as a therapeutic question. So same is the situation here, and I agree with Deepak that doing the diagnostic test evaluation is going to be very, very challenging. In any case,
recording stopped.
For clinical practice, what we need is a therapeutic question.
Sure, sir. Okay.
So you can try, the group can try to reframe them, and I'm sure they will be. But just since you've listed parameters like CFT, NI, BP, IBP, so maybe PI and PVI, they want to cover that also, because now they are available.
Yeah, so that's the next section I'm opening up quickly. Sorry. So my bad, actually has been really busy, so couldn't combine. It was supposed to be combined before this thing. So this is the next slide, sir, or next section. So we are adding lactate.
Okay.
So lactate, PI. So lactate, role of lactate in the measurement of assessment of tissue perfusion and shock versus clinical monitoring. Again, we'll reframe. Is there a role of lactate in diagnosing shock or monitoring? And then PI, is perfusion index combined superior to or alone to heart rate changes in the early detection of shock in neonates? Secondly, does PI measurements absolute value or trend analysis leads to early diagnosis of shock compared to the other clinical parameters? Is near infrared spectroscopy based assessment of low renal perfusion is superior to the clinical detection of the shock? And other newer modalities such as PI, PVI. Now PVI needs all those non-invasive cardiac output versus PI. Again, this is a broad question. There could be sub questions based on each modality versus clinical parameters, whether they are superior. And a PVI definition for hypotension is more accurate than clinical assessment. That's again a separate out. So we are trying to address PI, PVI needs and non-invasive cardiac output monitor and lactate in this section. So again, we can come up with the specific questions and then we can share the document again. But again, comment on this part.
So I think again, as Ravi Shankar was trying to say, I mean, just keep in mind that we are a large population of SNCU, where also shock will be encountered, and they would have access to maybe clinical, maybe pulse oximeter, or maybe NIV. So do have questions related that in those scenarios. So for example, which clinical parameters you have CFT, for example. So our heart rate variability you mentioned, BP you mentioned. So just think from their point of view also that how they can also efficiently diagnose shock and ensure.
So one suggestion is that we are comparing these newer modalities with clinical assessment. So the newer modalities information, it is unlikely to be available alone. So it can be reframed as clinical versus newer modality plus clinical. So that may be a better kind of.
Yeah, so that will be a therapeutic question.
Yes.
Whether adding newer modalities we can define improve the
outcomes. Correct. Got it. Fine. So going to the correct, sir. Thank you. Going to the next one, just a question on the volume expanders and then followed by that on the vasopressors. So we thought there are quite a lot of relevant question needs to be answered in volumes because that's something a lot of people are using as a first line. So in that, so we have about 7 questions in the volumes. So is volume expander used as a first line treatment modality for all etiologies of shock? So you give bolus for all of them. Whether that's what we are trying to address. Does crystalloids versus 5% albumin as fluid bolus for shock management? So addressing 2 choices, or ringer lactate versus normal saline as a fluid bolus, or then fluid bolus is 10 ml versus 20 ml in per kg in shock. In that we also discuss whether for cardiogenic we should talk about 5 versus 10. Then fluid bolus is over 30 minutes versus fluid bolus is over 60 minutes. Is the fluid bolus administration is based on clinical assessment alone is equal or inferior to the echo based assessment? And then bolus administration of shock influenced by the PVI measurement compared to IVC volume by echo. So again we are adding a bit of a diagnostic tool for advanced centers where the facilities are there, whether you decide bolus based on the echo or PVI criteria. So these are the questions on volumes. Again, open for questions.
Number of boluses.
Correct. Okay. Yes. Correct. So whether maximum how many? So for that I think I had a slide. Yeah. So that again. So this is the slide which I wanted to address here about the maximum volume to be given, and this recommendation I came across on a pediatric critical care, and they are saying it's applicable for NICU as well. It's in one of the Danish talk I was listening, and in Canada they are following this. So whether we add how many boluses of 10 per kilo or 20 per kilo, and their recommendation is like in high resource don't give more than 60 ml per kilo, and in low resources maybe 10 to 20 ml per kilo, maximum up to 40. So I don't know. So I was not aware. I'm not like specifically following that. We are generally liberal in giving in septic shock. So any comments on this recommendation, sir?
So I think basically you need to have that question, and when you review the evidence,
Then
you
we can come up.
review
Correct.
the basis of these guidelines, whether how many units were studies were there, and
Correct.
term or preterm units may not be same guideline.
Correct. So number of boluses or total volume maximum given, that will be the question, sir. Isn't it? Yeah. Got it. Fine. And the last part is the
So one comment.
Yes, Sajan, Dr. Sajan.
So in relation to the volume, you can have say this volume or more than this volume. Say you can have a put of 20 ml and more than that.
Okay.
And the timing is also for the time can be just like 60 minutes and like you said 30 minutes or 60 minutes. So less than 30 or less or more than 30 minutes. So you can actually because you might find somebody has used a different time point than 30 and 60 minutes.
Like slow versus fast feeding improvement.
When you define a low resource setting, it's quite challenging. I mean, we are in a low and middle income country, and there is a lot of difference between a low resource setting and a low and middle income country.
Correct. In the same country, there could be low resource. Yeah.
And even in when I participate in ILCOR, many people take an offense when you say that you are in a low resource setting compared to when you are in a low and middle income country.
So whether we address that question for SNCU separately, and in SNCU whether we can give a number of boluses, something like that.
So instead of using that term as Veera is saying, I mean, option can be okay. What should be present? You know, when you're saying high resource setting, what do you mean? Like, are we talking of some, let's say level 3 facility or some definition can be given. Okay, this setting is applicable, but it will depend on what you find for the neonatal evidence actually.
Correct. Right. Okay. Sure, sir.
Give us thing.
Okay. Sure. And any other comments, or should I move to the last? Deepak, sir.
So I think they have identified that subgroups. I was going to say that for most of the questions, subgroups will become important for you, because there are many other CPGs which are directed at preterm babies or term babies. This particular CPG will cover extremely preterm, term babies. And for example, issue with, septic shock, if you look at septic shock guidelines, current guidelines are only for term babies or young infants. They may not address preterm babies. Similarly, so for most of your questions, you will have to address that subgroups, those group, even if evidence is not there. So some recommendation will need to come.
Correct.
And for each question, recommendation have to be given for both SNCU and NICU, unless the patient population is specifically only for NICU. For example, less than 28 weeks baby, you may consider only will be managed at NICU, but a 36 weeks baby with shock, septic shock can come in NICU, it can come in SNCU, so may have access to echo, may not have access to echo. So the recommendations have to be stated. And as we will go along, we have the framework for that in this particular grade methodology. That framework exists to give separate guidelines for subgroups or different settings. That is one thing. And second thing, which Dr. Sadhan was saying, that 30 versus 60 minutes or 10 ml versus 20 ml. So we can take an example from slow versus fast increment of feeding. So they define slow increment of feeding in a range, and similarly fast increment of feeding and again in a range, 30 to 60 ml per kilo per day. So similarly for your fluid bolus 10 to 20 versus 40 to 60 or 30 minutes or 10 to 20 minutes versus 45, 60 minutes or 120 minutes, you can define that slow bolus versus fast bolus. So that when you include studies, everything can come into that broad question.
Dr. Nilesh, Dr. Udayandar. I think point well taken, sir. Correct.
One more thing, can we reframe this point number 6?
Sure.
Is the fluid bolus administration based on clinical assessment equal to or inferior? So can we make it, echo-based fluid administration is more helpful than clinical-based alone? So that, just trying to...
Sure, got it. We can frame it that way.
So one more thing is point number 7. You told about IBC volume by echo, but I mean there are other parameters as well apart from IBC. So maybe you can think of uh, the other parameters clubbed as a modality, other eco parameters clubbed as a modality in addition to IPC. For example, there can be a peak velocity variations in the aortic outflow tract. The dynamic indices are there.
Sure.
There are some other also.
Stroke volume variation, SVV kind of, yeah.
Yeah. So basically, you can club them and
Yeah.
in a basket of kind of
So
in comparison to the other like PBI, etc.
Sure, sir. We can include that. I think we were getting influenced by the studies presently. So this question was specifically designed for a particular study which is looking at this comparison. So, but yeah, we'll make some specific list as well. Okay.
मेरे को ऐसा feeling आया कि because the questions are going to be too many, like you are going to have say 30-40 questions, you have to ultimately squeeze these questions
into
to
20
a respectable number, which could be somewhere between 10 and 20.
Okay,
and then you need to drop a few. I think this will figure out under drop.
I know, sir. Yeah. Sure. Our initial idea was to 30-40 and come up with you to 20, but like we thought we'll show these questions first and then discuss and then come up with the final questions. So yeah, we'll frame the final under 20 only. Okay, so last.
So what happens? What we recommend, as you just open the document, I will speak in parallel that what we recommend that each question should be addressed by at least 2 members of the group. Okay, so typically, if each member is given 2 questions, so each member will end up working on 4 questions.
Correct.
So 3 to 4 questions. So working on each question is like conducting a mini systematic review.
Correct.
So it is not an easy task. So as Dr. Sajan is rightly saying, you have to, all these questions are important. So you have to either make them in such a way that one question covers many aspects, but it is specific enough. Okay. Or you need to drop some question and say that we did not address this particular thing.
Yeah. So we were planning to do rating amongst all of the group once we discuss the questions and we are agreeing. So we'll make a list of final 25-30, we'll rate them, and then the top rated questions 15 to 20 will include, and we'll share that document for the other group members to share. Maybe I think we are maybe one step behind, sorry, but we will do that. Yeah.
No issue.
Yeah.
So the same.
What is important, Kiran sir, is that we have to see what questions can go from E to D. Evidence to decision. Recommendations. We can only judge that once we have the search strategy ready and all the things ready and the evidence tables being created. Before that, we don't know. We don't know which questions are eligible to go to recommendations. Though grade says that even if you have the minutes of evidence, you have to give a recommendation for the clinicians. But what all questions out of these that we have framed will have enough studies and can go from evidence to ETD. That's something that we have to see post-hoc.
Yeah. True. Fair enough. If there are no other comments, we'll go to the last section, which is vasopressors. So again, here also we are trying to address few sort of combination of questions, a lot of them, but we will sort of come down to a number and come up with the specific questions only. So if I can read, so it's dobutamine versus dopamine as the first line of management in hypotensive preterm infants. So in preterm specific group we were talking, preterm with shock. Then dopamine versus epinephrine for the first line inotrope in septic shock. Dopamine versus dobutamine in septic shock. Norepinephrine or noradrenaline versus dopamine as a first line in septic shock. Choice of ionotrope first line agent in the COIS. So again here we were trying to see whether dopamine or dobutamine versus epi or some that combination we'll try to include here. Then milrinone versus dobutamine in cardiogenic shock. Dopamine versus dobutamine in birth asphyxia, so shock related to perinatal asphyxia. Adrenaline versus noradrenaline in the management of shock. So again, we are trying to take multiple combinations. Noradrenaline versus vasopressin in a distributive shock. Norepinephrine versus dopamine in PPHN with shock. Then what are the maximum doses? We can go up to 10 versus 10 to 15 in dopamine. And then some questions related to the administration and tapering.
So sorry, doctor,
Yes.
can I interrupt?
Sure.
So from a clinician point of view, the question comes that if a baby has shock, should I start dopamine, dobutamine, adrenaline, non-adrenaline, milrinone? So if you take pairwise, then how the recommendation can be framed? So like septic shock, if you compare dopamine, dobutamine, and you let's say that question says dopamine may be preferred over dobutamine. And next question is dopamine versus epinephrine, and then that says
So
epinephrine may be preferred over dobutamine. So
Got it.
this is a typical scenario where you have Vera with you, so network sort of meta-analysis you can consider.
Yeah.
So what will happen that all these questions will be clubbed into a single question.
Single, yes. We said that actually exactly. And again, as I said, we were trying to include this, but yes. So first choice of inotrope for a septic shock, that will be a question, and then we'll compare different combinations in that. That was we thought, yes, agree.
One more suggestion.
Yes, Dr. Sajan.
Actually, the cardiogenic itself is a big basket. You know, the PDA will also come into that, and birth asphyxia will also come into that, and some obstructive. So basically these two. So they may have a different approaches points. So उसको कैसे variability को handle करना है? I think that what Dr. Deepak is saying, the network kind of a thing. But somehow we need to think about those lines.
Correct. That's what I think. All 4 types of shock, we should be able to give some recommendation key for every type of shock. This should be your first choice. This should be your second choice. Something like that we were thinking. We should be able to come up with some recommendations. And for that, we had these multiple questions arranged. But I think we'll club these questions together for a shock wise, and then we will see how we can address them.
So I just wanted to ask again. I'm not thinking from a echocardiographer perspective. A clinician will not say cardiogenic shock. A clinician will say birth asphyxia baby with shock, or extremely preterm baby who develops hyperperfusion in first 24 hours, or a baby who has low diastolic BP on day 3 of life, or a baby who has sepsis with shock. So what should be the starting point? I just want to park this question. Maybe Dr. Sajan can answer that. When you look at guidelines, so starting point should be cardiogenic shock and echo definition of shock, or it should be clinician's definition that a scenario like my time Mohit also teaches, the baby with asphyxia has shock. Now that baby may have cardiogenic shock, that baby may have hypovolemic shock, may have some element of septic shock if risk factors of sepsis are there. So I think we should be more starting point should be clinical presentation rather than delineating first as cardiogenic and redistributive or other type of shock in which hypovolemia is there.
Yeah. So one thing which stands out is birth asphyxia. Birth asphyxia related is a kind of which you can differentiate clinically. So I agree that it should be a clinician based approach rather than the etiology based approach. So the 2 distinct things which can stand out is the transitional circulation, like ELBW babies in the first 12 hours, they will not happen later on in life. And second is severe birth asphyxia and shock following down in the few hours of life, first day of life maybe. So rest is, I think, we can.
Yeah, so maybe 4 scenarios. Sadhnu, you are saying asphyxia, extreme preterm in first 12 hours, septic shock, and history of blood or volume loss. Clear history of blood or volume loss, hypovolemic shock like diarrhea. So these 4 scenarios should cover maybe 90-95% of babies, and then maybe you have some scenarios which are left out, which can be left out from guideline perspective if you're covering more than 90% of scenarios.
Understood, sir. Sure. I think that's, yeah, we'll frame it very simplistic for clinical scenarios. Yeah, got it. Any other comments? Should I just go ahead with the two more sections? Just for administration of inotropes, in case of multiple inotropes agent used, can they be mixed in one fluid, or should they be given separately? That one again practical question we thought should address. And then central versus peripheral line of administration for inotrope. Is it must to have a central line for giving inotropes? That's question we would like to address. Then tapering the inotrope.
So before you go to the
sure, yeah.
Sorry for interrupting again and again.
Sure.
The first question here is a sort of background question. No one will do a study that you are mixing or giving singly. So if that can be answered just as a statement in your background that pharmacology says that they should be mixed or not mixed.
Correct.
So it need not be a upfront graded question. It can be just a sort of statement based on background knowledge.
Okay. Sure. Okay. Perfect. So similarly for the central line also, then can be you're thinking we can make it as a background as well, or only for first question?
You can consider this.
Second one.
This can be foreground question. Second one can be foreground.
Okay.
Sir, just one thing. Central line and peripheral line, then again it is now dose dependent. So I think so. Like sir, it cannot making it a background will be bit.
No, we will.
We're not saying background.
No,
not saying background. It is an important question. It should be taken foreground, not background.
Foreground.
Yes.
Yes. Foreground. So, and the last section is targeting the inotropes. So during tapering, which inotrope should be weaned first? So again, is it the last added inotrope should be weaned taper first, or the first added inotrope? Then once stabilization, how frequently inotrope agents must be tapered? How frequently? So is it every 4 to 6 hourly, 12 hourly, whatever like that? And then gradual tapering versus abrupt stoppage of inotrope agents after initial stabilization of the inotrope. So we thought these are also relevant questions. So again, these three can be combined in one question in some form, if possible. I think that brings to the end of our questions. So again, open for questions, discussions, and suggestions.
Oh, sorry. Hello.
Yes.
Yeah. So other supportive things like
I think
hydrocortisone.
Yes. I think that pharmacotherapy. Yeah, one sec.
The PCB cutoffs.
Yes.
Hematocrit cutoffs.
Yes. I think we have one more document. One sec. Sorry. Pharmacotherapy. Because we had questions on hydrocortisone and FFP and intragam and all those things. Just trying to. Surpreet. Sorry. One sec. Gunjana, do you have the document on the pharmacotherapy? I'm just trying to pull up in my computer.
Yes, sir. I'll take it.
Can you share? Can you share, please, from your end? You can present that, please.
So while it is getting opened, just one suggestion, if I can make that, let's look at typical flow diagram of a baby who is going to be managed with shock. Hello.
Yes, sir.
And when we prioritize questions, let's try to make that flow algorithm evidence-based. At least that should be the target. So that flow diagram, you can say that giving bolus of 40 or 60 has this much evidence. Starting epinephrine first or dopamine first has this much evidence. So that should be our main objective while prioritizing, which I think, so that at least that part is, because ultimately I feel that you will need to drop many questions. So you will have to prioritize.
Sure, sir.
And while Gunjana is going through things.
Sir, I am unable to share, sir. I have sent it to you again.
Okay. I'll open it from my end. Okay. I'll open it from my end. Yes, Veera.
Kiran sir.
Yes, sir.
this is something that has been lingering on for a long time. Each of these questions are a potential systematic review, and dissemination of evidence is
Yeah.
important for not only for India but for low
Everywhere.
and middle income countries.
Yeah.
And we should have a clear-cut guidelines as to where we will target, which journal we will target. Whether we want to bring up Journal of Neonatology, NNF's journal, or we want to go to IG.
Please. Yes.
So this thing has always been there with Suffolk review. We actually missed the opportunity. It's difficult now to redo again, but we should have a clear-cut policy as to
Yeah.
what we have to do once we do everything.
I think,
how
yeah.
to disseminate the evidence.
Yes.
Dissemination of evidence is the most important aspect.
Agree.
So I would like to get the guidance of Praveen sir and others in this aspect.
Yeah, so we are very much geared to put the effort, but yes, I think this is important we can address at the beginning. And Praveen sir, you want to comment on that, or should I just finish the questions first?
Yeah, maybe. So I think, Veera, what you're saying is right. So basically, when so much of effort is going to be put in, so as a byproduct, the group can obviously bring out publication, and obviously there can be more than one publication. So, in the total guideline or the job aid, which will be the primary goal of this CPG, is to simply help our practitioner friends. Okay, this is the guideline, and you can follow. Now, the systematic reviews or whatever kind of meta-analysis going to be done for individual questions can be published, separately also. What Journal of Neonatology is publishing is a summary of a guideline, a clinical summary. But since for each question you may have much more data, many more tables which have been gone into creating the meta-analysis, so definitely they can be targeted for a better journal rather than, So Journal of Neonatology will not lose the guideline publication, but what meta-analysis is done, systematic review, so easily maybe 2 or 3 you can bring out, not an issue.
Of this. Sure. Thank you, sir. So continuing, so 2 more sections, sorry, end of the day. So
Thanks, sir. Thank you. I mean, this is something that we had an issue even in the surfactant guidelines. So, we missed the opportunity there. I mean,
even now, I think, although the Journal of Neonatology would have published the guideline, but suppose within surfactant you have a specific question where a lot of effort went in, and that is not really available in the literature. So your group should publish it as a separate systematic review, not an issue.
Thank you, sir.
Thank you, sir. So continuing antibiotic questions. So whether antibiotic should be administered in all types of shock, irrespective of the etiology. So that first dose of administration straight away. Again, we will simplify. In neonates with suspected septic shock, should by administration of antibiotics to be done within 1 hour of recognition. Timing of the antibiotics, again same. Choice of antibiotics in the management of septic shock. So should we give that broad spectrum should be the first line, or first line should be the first line agent kind of thing. So on the choice of antibiotics, and then duration of antibiotic therapy, we will say on the septic shock 7 to 10 days versus 14 days. Then other supportive management, should bicarbonate administration in neonate shock to improve cardiac function. So it should be routinely administered. Again, we'll reframe it. Should bicarbonate be routinely administered? Timing of administration of hydrocort in the treatment of shock, within first 6 hours or before the sort of addition of the first inotrope, or along with that kind of a question. Then dose of the hydrocort to be administered in the shock, 5 kg or like high dose versus low dose. Duration of the administered steroid in case of neonatal with shock, 5 to 7 days versus 40 to 72 hours. So again, all these 3 questions can be combined in one question. And then when should the intubation be performed on neonates with shock, whether early as soon as the diagnosis is made, or late only in case of fluid refractive or catecholamine resistant shock. And then other remaining is role of adjunct therapy like pentaglobulin, GCSF, GSSF, lactoferritin, all we combined. So additional pharmacotherapy in shock should be administered as adjunct or not. And then role of exchange transfusion in the management of septic shock. So again, so these are more of topic. We will frame specific questions, but again open for discussions and comments, please.
So Kiran, in this, lot of questions are related to management of sepsis, which already are covered under the sepsis CPG.
Okay, right.
So
Okay.
you could actually
We could
remove.
exclude that then. Okay. We'll go through the sepsis CPG and then we'll.
And then again there will be some questions where, for example, you can, if you can go down, I think just go down. No,
up.
sorry. Up. So, for example, antibiotics, whether antibiotics should be administered and when they should be administered. I think, it will be very hard to say patient presenting with shock, antibiotics versus no antibiotic, and whether 1 hour or 2 hours. I think these can form again background or some standard statements that a person coming with shock, you are bound to give antibiotics first dose as early as possible, and as per the standard guideline within 1 hour. So I think such questions, because you have a lot of questions, so these can be simply moved to the background.
Okay, sir.
Yeah.
We came across one of the pediatric septic guideline where they had specifically answered, and they were trials on that actually. But in newborns,
Exactly.
probably you don't need. Okay.
So I think in any case, so once you kind of reframe your question and make a list of maybe whatever number, and you send it out for prioritization.
Sure.
So then we see what comes on the top.
Got it, sir.
And Praveen sir, sorry, it's a generalized thing, not just related to this CPG, but the thing of us, getting into ILCOR and having our say in ILCOR. I don't know how. There was 1 or 2 meets regarding that. But there is no progress related. This is not related to this shock thing, but I don't know where we are as of now.
Say it again, Veera. I couldn't hear your initial.
ILCOR. So be specific, Veera, for the ILCOR.
Yeah, I'm trying to be specific, but where do we stand now in being incorporated into ILCOR as a? We have 25 to 30 million birds per annum, and
so you're saying we should be in ILCOR making the recommendation for the world.
No, there was a couple of needs, and there were issues, and I talked to Dr. Ramji as well. It's headed by anesthetist, I think, and there are some issues. I think we should have our say as far as newborn care, and the recommendations that they make are predominantly related to high-income countries. And where do we stand now? What is the progress related to we joining ILCOR as a group?
Okay.
That is something that we should seriously look into it.
Okay, we'll find out. I'm not aware of what has been happening, so I can discuss with Dr. Ramji and find out.
Thank you, sir.
Any comments on from anyone for the questions? Bicarbonate specifically and hydrocortisone, anything specific?
Bicarbonate भी रखना है question.
रखना तो पड़ेगा सर, मतलब like routine देना है कि नहीं देना है सर, उसके ऊपर I think we thought it's important because everyone is giving, even if it's discussed, don't give another thing. I think there is a survey which again addresses that most of the people still prefer to give. So I think it is an important question.
Okay.
See, this most of the shock presentations are unclassified. So we don't know what is it initially, because it is very tough to say whether it is a cardiogenic shock or clinically. So we should also have a question as to what is the timing of echocardiography. At what time it is mandatory to have an echocardiographic evaluation of a baby presenting with shock. Maybe that's because at what point do all the babies require echocardiography when we have access to it, or no? That's an important question. I feel where do we
Sure.
incorporate echocardiography in this line of management? At what point?
And so that will include even a question for referral. So those where facilities are not there, whether they should refer to higher center for echocardiography and further management, sort of, role of echo
So
and
that
timing.
brings one more question, is that how do we transport a baby with shock? Because then it's a very tough thing. Is it safe to transport them with shock and all? So transporting a baby who is hemodynamically unstable, which could be an important thing.
Yeah, coming to Ravi sir's question, we should have whom we are targeting, the target audience, level 2, level 3. Once we make that clear, I think these things will be sorted out.
Right. Oof. Yeah. Right. So I think so in the group we'll have a discussion. We'll come up with some streamlined questions. We'll share. Maybe we'll share about 20 to 30 questions, and then we will again take some opinions about which will be the final 15 or 20 questions.
So this Deepak, maybe you can suggest. I am not sure whether you should have questions on transport, because there is a separate transport CPG. I don't remember whether this particular question is addressed, but in any case, when you say transporting baby with shock, it's highly unlikely that baby have isolated shock. There will be respiratory issues, many other issues. So basically, we're talking of transporting a critically sick infant, a sick newborn. Which may be beyond the scope of this guide. There are many other questions will come related to transport itself. Already you have a long list of questions. But when to refer definitely should be addressed, so that because you're addressing both SMCUs and level 3 units. So when a level 2 should refer to level 3, that should be it.
Sure, sir.
Agree, sir. What about role of prostaglandin in shock? Do you want to address that?
Oh, okay. Probably only with shock related to PPHN and that kind of thing, or cardiogenic shock, ductal dependent or something like that.
No. Again, clinical scenario, term may be presenting with shock on day 7 of life.
Correct. Certainly. So without even echo diagnosis, you start prostin as a first line. Thinking is arch. Yeah. Okay. That way. We did not discuss that specifically. But,
Finally, Praveen sir, DTA, most of, I think the questions that have been framed will have a DTA meta-analysis. So, most of, we have to involve a good statistician in that. You can't just do it just like that. So is it possible, to involve someone outside our country who is good at doing DTA meta-analysis?
So Veera, I think the first attempt the group is going to make is to convert these questions to more of therapeutic questions.
Okay.
And then we can see if still it is required, it can be explored. But preference will be if the questions can be transformed to
simple
therapeutic.
Yeah. Okay, sir. Got it.
Okay, sir. There is an Italian statistician who is very good at DTA meta-analysis, and he's quite a good guy. He's interested in doing that. If possible, we can include him, provided it's okay with NF. And
because see, our primary aim is to have guideline which is kind of used by the practitioners, the large
Yes.
number of practitioners.
Yes.
So hence therapeutic questions will be more relevant.
Yes.
So let's see how the group kind of rephrases and then one can.
Sure.
Yes. Okay, sir.
Fine, sir. So that's it from my side, sir. If any other final comments or any suggestions, questions.
So maybe Ravi Shankar, Shashikant,
This is the full document.
Sajan.
Actually.
So anything from your side, Sajan, Ravi Shankar?
I think all the things have been beautifully covered, sir.
Supreet, do you have anything?
Somebody has earlier mentioned something. Alone versus okay. Okay. A chat box also. I think most of the comments we are addressed.
वो note कर लो chat box.
हाँ. Okay, sir. Duration of as active agent. Okay.
So Deepak, anything from your side?
No, sir. I think we can come to the next steps for this group.
Yeah. So what should be the plan? Timeline.
So I think the next should be make these questions more specific. And once we have made them more specific and try to make them from a therapeutic point of view, then these questions can be sent to a group of members, maybe all CPG members, different CPGs working on different CPG for prioritizing. And then you will get some idea about prioritization. Of course, you can override those prioritizations, but at least you can take, and I think that group wisdom will be much better than that we, from our side, we prioritize.
Okay.
And once that is done, then I think we'll need either online review or a presentation again. So what can be done that you make a Word document or Google Doc and share with all the reviewers and editorial members, and then they can comment on that, and then you can finalize maybe another 2 weeks, I think, sir.
Okay. Can be done.
So after 2 weeks we can have the presentation. So maybe if you can mail this
End of this week.
Yeah, that is.
Okay, sir. We'll do so.
See, either you can mail or if preferably Google Doc will allow
Doc, and
everyone.
I'll email the link of the doc to everyone.
Right.
We'll do
That
that.
will be the easy way.
Okay. We'll do that, sir.
Sir, Praveen sir, finally, would we have an access to Providence from Linda?
No, not yet.
It would be much easier.
Yeah, I know. Definitely next year. Right now we don't know.
Okay, sir.
All right. Okay. Thank you. Then thank you everyone for the time and and suggestions. We'll address. Sir, is there a possibility your recording will be shared? Just if you forget something.
Yeah, we'll try to share whatever has been
recorded. I think it stopped halfway through, but it's okay. I think.
It stopped somewhere. There was some problem. It stopped.
Yeah. We've noted most of the things, but just to make sure we're not missing out on anything, if you possible, you can record. Okay. Thank you everyone, and we'll see you in 2 weeks time. I'll send the documents. Okay. Thank you.
Bye.
Bye.
Thank you.
Bye.
Thank you.
sir.
Thank you. Bye.
Thank you very much.
Okay. Thank you. हेलो क्या हाल है नहीं अच्छा किया तुमने
Some hard questions, but
नहीं आई थिंक इम्पोर्टेंट है Yeah, we can't be fooled like you know इतना effort नहीं waste होना चाहिए था लास्ट वाले इसमें से 5-6 पेपर्स होना चाहिए था
That's affected thing. We put in 2-3 years of effort.
और क्या
And
और क्या सीरियसली उसमें से 5-6
नहीं
पेपर्स
हुआ।
नहीं हुआ ना कुछ भी वही तो और क्या उसके लिए क्यों रोक रहे हैं अभी भी हम लोग नहीं कर सकते क्या और भी कुछ उसमें से
अभी again said that